morning. My name is Mark. I'm the rector here at St. Bart's on behalf of the vestry and the team here. So grateful you all could join us this morning. This is a special morning because sadly, the pandemic is worse than ever for us. And it's hitting us real here at St. Bart's, let alone in our community and our country and the world. And so we've been blessed at St. Bartholomew's tenfold during this pandemic. We've had direct access to amazing healthcare leaders and community health officials. And that's on a grand scale. So Dr. Jamal on a national level, Dr. Cheryl here at UCSD and locally, they both live here. They're married, by the way. And so grateful I got to know them before the pandemic so we could tap into our relationships and pray together. I'm also very grateful for that, just to be able to pray with you all and to know that I've had and continue to have an opportunity to pray with Dr. Cheryl and Dr. Jamal as we go through the journey of being faithful to our Lord and Savior Jesus Christ and to do what God calls to do in our vocations. So Cheryl and Jamal, thank you very much for saying yes to Jesus 1,000 times. Thank you for 1,000 times for saying yes to serving others and the health of others. Putting others first is something that many people here in San Diego can appreciate, especially those who have worn a uniform or worn a badge or served in hospitals. And yet it's a whole nother can of worms during this pandemic. We're acutely aware, but we have many of us, some of us have not been actually in the hospitals themselves on the front lines as you both have been. And so we pray for all who serve our country and serve the health of everyone today. And so grateful for you. My friends, just offer a prayer as we begin. The Lord be with you.
And also with you.
Lord God, we give you thanks for this day. We love you, we praise you and bless you, and we give you thanks for your Son, Jesus Christ. We give a special thanks for the gift of your Spirit that guides us together in ministry, binds us together through our baptism, and has called us to be your servant, that is serving others, that is following your way of love. Help us during this time, this next 45 minutes to an hour. Open our ears, open our eyes, open our hearts. We pray especially for Cheryl and Jamal as they share their experiences and wisdom. And we pray for that we may listen and then as a community have a conversation about how we are called to respond to the needs of others today, tomorrow, and the year ahead. We pray for all who serve our country today, all who serve in our public health systems, and pray for all who are struggling with COVID-19 and any life-threatening disease today. Have mercy on all of them and protect them by your grace. Amen.
Amen.
Dr. Cheryl, Dr. Jamal, the floor is yours.
All right. Thank you so much, Father Mark, for inviting us into this space. Thank you, Demetrius, for that beautiful introduction. So what Jamal and I are going to do this morning is to provide some brief overarching comments, and then we want to spend the majority of our time in discussion with you. I'm going to start by giving some public health perspectives, and then Jamal will follow up with perspectives on the vaccine, and then we'll take your questions. So as it comes as no surprise to anyone on this call this morning, the country has experienced over 17 million infections of SARS-CoV-2 and resulting COVID-19. There have been over 300,000 deaths. Across our nation right now, hospital intensive care units are at or even beyond their capacity. Here in California, our state officials have ordered thousands of additional body bags, refrigerated storage units to serve as portable morgues. The cases and the mortality rates in our county continue to rise every day, seemingly worse than the last. Yesterday, we were at over 3,700 infections in one day right here in San Diego County. The public health teams that are dealing with the pandemic can barely get to do the public health interventions that are necessary to keep us all safe. Right now, we can't do the interviews of the people who become infected within 24 hours of them being infected. So our public health system, our hospitals, and our health systems they're stressed right now to a breaking point. The other thing that's really interesting is that for many of us, these aren't just numbers. These are names of families. They're names of our other loved ones. And when we start to see this volume of community transmission, this sense of 3,700 people being infected and detect those infections detected in one day, we know that the infections go up in those who actually provide care as well. So in our frontline workers, our nurses, the custodians who take care of our facilities, our doctors, they too get increases in infections when there's so much virus out in the community. When we ask people to not gather, that's a public health order. It's not just about what people are doing when they get together, but it's about the fact that if we're not traveling together with each other, we decrease the use of cars during this time, which decreases the amount of motor vehicle accidents that happen during this time. And it decreases the need for hospital beds, allowing that availability to be there to individuals who have complications from COVID-19 or other life-threatening illnesses. If they have heart diseases or cancers, or they have a bad slip or fall or other accidents, they can have space in the hospital. When we talk about, restrictions on travel, it's not just about, having to wear a mask in the airport or on an airplane. It's about trying to keep the gains that you make in certain communities sustained, because we're not now taking infection from one region into another region because of this movement and inadvertently transmitting the virus. So I know everyone's familiar with the basic, prevention methods: good hygiene, washing our hands, remaining physically distant, at least 6 feet between us, wearing a mask, protecting the ways that we potentially shed virus out toward others or put virus into our bodies, and monitoring ourselves daily to see if we're developing symptoms that might suggest that we've been infected with SARS-CoV-2. However, there's a lot of frustration and there's a lot of fatigue. And if we aren't able to find that motivation and purpose and positive action, then we're going to have to put a tremendous amount of resource into mitigating or working our way through those who get infected because we weren't able to prevent it. So I'll just, stop here by saying, watching our frontline healthcare workers and other volunteers this week and last week at their first doses of the COVID-19 vaccine, there is reason to believe that after all of these months of uncertainty, this pandemic is indeed going to end. The challenge now is to keep ourselves safe until enough of us have been vaccinated and our communities can benefit from this protective community immunity. So it won't be easy, but we can do it. And I'm going to pass it over to Dr. Gwathney now to talk about where we are in regards to the vaccine.
Well, thank you so much, Dr. Anderson. Thank you, Father Mark and Mr. Greg. I really appreciate the time. I wanted to talk about the vaccines, and it's a ray of hope right now, light at the end of the tunnel. As a family medicine physician for over 20 years and currently active duty in the United States Public Health Service, I've been giving vaccines for years to children, to adults, promoting vaccines for quite some time. And this is a great opportunity. I wanted to talk about 3 different sections, maybe the process of how we got here. Are the vaccines safe? Are they effective? And how we move forward. So kind of the process, was it fast? Definitely. It was certainly faster than the normal process. Did it need to be, or should it have been? I think yes. Usually when we're dealing with vaccines, the diseases aren't killing hundreds of thousands, millions of people at that time. So we needed to have something a little more urgent. And that's why the EUA, Emergency Use Authorization, came into play. And we could talk about the difference between authorization versus approval later, but I think it's something that needed to happen. The vaccines themselves are safe. And I'd like to point out the vaccine is this mRNA, as we've talked about, many people talked about, and we have mRNA going on in our bodies every second of every day. It's the normal process that our cells regenerate. It's a normal process that we make proteins. So mRNA is nothing foreign to our bodies. And basically, this mRNA makes one of the 29 proteins of the actual virus. The 29, it makes one protein, you make the antibody to that protein, and you get immunity. So there's no way to get coronavirus from one protein out of the 29. I want to be clear on that. And once you get the vaccine, you can't give it to anyone else either. And so it is safe and it's effective. So the effectiveness part of it. So we go into, you hear 95% effective. And so how do they come to those numbers? They took thousands of people. I will say having 73,000 people in the studies, 30,000 or so in the Moderna trial, 43,000 in the Pfizer trial is gargantuan. Usually we have 3,000 to 5,000 people in a vaccine study. So having data on 73,000 people is a lot. And it was obviously faster because people were more interested in getting vaccinated and giving more data from a public health standpoint. So it's important to realize that this is effective and that we come to this point by 73,000 people and they look at how many cases of coronavirus happened. 95% of them happened in the group that only received placebo or saline, and 5%, 6% happened in the arm that actually received the vaccine. So that's how they come to those actual 95% effectiveness rates. It's important. I'm an advocate of vaccines. I've been for many years. I'm also the type of person that I will never ask anyone to do anything that either I would not be willing to do myself or have not done myself. And so back in August, I'm actually part of the Moderna trial right now. So I have yet received my first vaccine in August, second dose in late September. I had some arm soreness. I'm about 99% sure I received the actual vaccine versus the placebo. And I can get into, I was donating blood at the Red Cross and had negative antibodies beforehand. And then after getting my vaccines, I had positive antibodies, and I've had positive antibodies ever since. So pretty sure that I actually did receive the vaccine. I believe it's safe. I believe it's effective. And I think it will help us get to the end of this tunnel. Maybe some special topics. A lot of people are asking about pregnancy and the vaccine. Right now, the ACIP, the committee, is recommending that if you are pregnant and in the healthcare worker category, so that top category, that you may choose to be vaccinated. You should discuss that with your provider. The other categories may want to hold off until we get more data, because we don't have a lot of data on pregnancy. They did not study children or pregnant women in either one of these studies. There's a lot of talk about the Bell's palsy right now, which is a facial droop on one side. And we can certainly talk about that, but the numbers were definitely skewed towards the vaccine. So in Pfizer, there was 4 cases in one arm and 0 cases in the saline arm, and then 3 and 1 in the Moderna trial. So there definitely is a difference, but that wasn't any greater than what's normally happening in the country at any time. So there's a lot still to be learned about the Bell's palsy. And then the allergic reaction issues. I know a lot of people have been talking about that as well. And the current recommendations right now, I can say for the Pfizer, we're still waiting on the Moderna specific information. But the recommendations, I'll tell you about 5 different, what we call contraindications, like who should not get the vaccine versus who, is questionable. So absolute contraindications, you should not get the vaccine if you've had any allergic reaction to the vaccine or any of its products. And we say that for any vaccine. That's one. Number two, if you've had, this is relating to the allergic reactions. If you had an allergic reaction to any vaccine in the past, a severe reaction, what we call anaphylaxis, trouble breathing, big rash, you may have to get admitted to the hospital. So if you've ever had any reaction to another vaccine or any injectable, which means if you were getting chemotherapy, IV or IM, meaning in your muscle, any injectable, if you had any reaction to any injectable, you should not get the vaccine right now. Wait till we get more information. So it's not ever, but just right now. So those are two. And then what we call relative contraindications. Like, yeah, maybe you guys should hold off right now. One being, if you've had coronavirus in the past, they say you can still get the vaccine, but we know your risk of getting infected in the next 90 days is pretty low. So you may choose, you can defer for 90 days after clearing coronavirus. That's one. Number two, if you've gotten any other vaccine within 14 days. So they're recommending right now, you wait, you don't get any vaccines before you get your shot, and you wait 14 days after your shot to get any additional vaccines. So if you're in that 14-day period, they'll ask you to hold off on that. And then the last one is that there is a treatment right now called these monoclonal antibodies. So basically, we get antibodies 4 different ways. You know, you can get antibodies from getting the disease. You can get antibodies from actually what we call plasma from someone else, convalescent plasma. You can get antibodies from a vaccine, or you can get antibodies that's synthetically made in the lab, and we give you antibodies. And there are 2 different ones on the market now. So if you've gotten these antibodies, they say that could interfere with how well you respond to the actual vaccine. So you should wait 90 days after you've gotten these monoclonal antibodies. So those are some of the special populations that I like to talk about. But I will stop there and make it short and see if there's any questions.
We do have a few questions, Dr. Gwathney, and just if you could reiterate, one of the questions was, should you get the vaccine if you've tested positive for COVID? And just want to confirm that individuals who find themselves in that category should defer for a period of 90 days.
Well, you can defer, not that you should. Okay. You actually have that option. But you know, anyone that has had coronavirus and maybe you're 2-3 weeks, maybe you're a month out and you're feeling fine, you can get the vaccine. Not that you need to defer, but you can defer for 90 days.
Okay, thank you. Another question, is it true that once you're vaccinated, you cannot carry the virus or infect others?
So no, that's not true. So some of the things we don't know about the vaccine, we know a lot, and there's things that we don't know, like long-term effects from the vaccine. We don't have a clear idea on that just yet. We don't know if the vaccine will actually prevent you from getting disease. We definitely know for sure, it decreases how sick people will get. So you don't get severe cases, not hospitalized, not in the ICU, not on ventilators. But we don't know just yet, we will find out, but we don't know just yet if it prevents you from actually getting disease. So you could get the vaccine, you could potentially get a mild case of coronavirus, which then you could potentially spread to family members. Now, you also think the milder your case, the lower how much virus you have, which means less transmission. So it's better to get a vaccine, definitely, because you'll have milder symptoms if you were to get exposed, and less chance, not zero, but less chance of transmitting it to family members.
Okay, thank you. One of our participants wants to know, what is the youngest age you can get the vaccine?
Okay. You okay with me handling this, Dr. Anderson? Okay.
Absolutely. The next one's coming your way as well.
Okay. So interestingly enough, there was a lot of discussion about the vaccine. So Pfizer vaccine right now is approved down to 16 years of age, and the Moderna is approved to 18 years of age. There were a lot of, several of the no votes for the Pfizer vaccine. There were 22 votes for the Pfizer, and there were 17 yeses, 4 noes, and 1 abstention. And most of the no votes weren't dealing with is a vaccine safe or effective, but I don't think it should be approved for age 16 to 85 or so, because we didn't have enough data on the 16 and 17-year-olds. And that's where most of the no votes were coming from. So Pfizer is approved down to 16, Moderna 18.
Okay. And another vaccine question. Can you get the vaccine if you are currently undergoing chemotherapy?
That's an excellent question. So you're undergoing chemotherapy, so your immune system might be a little suppressed right now. That would be something that you definitely would want to talk with your provider about. They have not said that you shouldn't get it or that you can't get it, but you would want to talk to your doctor. If your immune system is already suppressed, then getting the vaccine, you might not mount that antibody response that you want. So you might want to delay, in between chemo treatments or things like that, and set the timing up with your provider. You definitely are allowed to get it, certainly, but that's a definitely interesting case that you want to talk about with your doctor.
Okay. One participant, I do not have a spleen. Can I get the vaccine?
Yes, you can. Yes, you can. No problems there.
All right. And yet another vaccine question. There are currently 2 vaccines approved. Are there others under development?
Yes, and I guess I'm a government person, and so I have to officially say there are 2 that are authorized, not technically approved yet by the FDA. So they're authorized, and there are many underway that are still in phase 2 trials, haven't gotten to that phase 3 yet. I know Janssen has one, AstraZeneca has another one that is getting close. Those are different formats, different viruses. They're adenoviruses, not so different than the mRNA platform that we see right now. But there are others that are coming down the pike, hopefully, to widen that support that we need.
Great, thank you. Dr. Anderson, we're going to throw one your way. Would you suggest that schools stay open for on-campus learning during the pandemic?
Okay, it depends. So right now, what is happening is that if schools were opened prior to the surge that we're seeing right now in infections, they have been permitted to stay open because likely the procedures that they've put in place for opening are working well, and they are able to provide, evidence of that nature. In the midst of a surge, it becomes less compelling to open a school and to have activities on a school campus if those things haven't already been worked out and ongoing. And so you'll find that in our state orders and in our county orders, they allow you to keep going, but they don't allow you to initiate at this time. Well, you might say, how could people, possibly have schools open at this time? Well, I happen to work on an advisory team for a large campus where we've had 9,000 plus students living on our campus. We've had another 20,000 plus return to San Diego County to learn from our campus. And so we've had an extensive testing regimen. We test individuals who have symptoms. We test those who do not. We're now up to once a week testing, but we tested for some time every other week. We monitor wastewater to get early signals of whether or not we might have infections on the campus. And we also have a very robust system of intervention when, not if, when we find infections, when we detect virus in the individuals who live and work and play on our campus. So when that happens, we have a big team who goes in to interview individuals, to figure out who their close contacts are, to determine if they're at high risk for transmission. Are they in congregate settings? Do they work and might expose individuals in their workplaces? And we also figure out if they may be at risk for seriously developing symptoms. We take all of this into account, and we have a team of 6 physicians, public health scientists, student affairs officers who every day monitor the state of affairs. So the answer is yes, it can happen, but it depends on if there are resources to do it well. So that's where I would come down on that.
Okay, thank you. Another vaccine question. Can my mom, who is 90 years old, get the vaccine?
The answer is yes. She would definitely fall into that, or fall into that 1B category, over 65. There have been many folks 90 and above who have been receiving the vaccine. Interesting note that it seems as though the older you get, the less severe any side effect reactions are. And that's because your immune system, as we get older, it decreases as we get older. So your reaction to, the actual vaccine is less. So they noticed over 65 have less reactions than the 18 to 65 age range. So yes, they could get vaccinated.
Okay. We have a technical question about the vaccine here.
Okay.
And it's regarding Moderna's vaccine, that they've unblinded their phase 3 trials so that you could check to see if you were in the placebo group or the active drug group. It seems important to let the placebo folks know they only received a placebo. Dr. Gwathney, your thoughts on that?
Interesting. Yes, there was a lot of discussion in both the Pfizer and Moderna VRBPAC meetings, the vaccine and related biologics, products advisory committee meetings, and the ethics around, vaccinating, not vaccinating. So I am of the opinion, certainly there are different ways of unblinding, and we can get into different studies and how you do studies. But I'm certainly in favor of opening it up to folks that when it's your turn, when you're eligible. So say I'm a healthcare worker, okay, I would get the vaccine in that 1A spot. But maybe if I'm, 20 years old and, don't have any chronic conditions and I'm lower down on the list, offering it when I'm available, when it's my turn to get it, not putting people ahead of term. That's just my personal opinion. And I've already received that email from Moderna that they told us, yes, we're going to, if you want to, let you know that if you were or are not in the vaccine arm, and 1 to 2 weeks after it gets approved, we're going to give everybody the vaccine. That's certainly what they're doing. And I think Pfizer is doing something similar to that as well, offering people. You don't have to be unblinded, but there are definite, obviously, ethical benefits of giving everybody the vaccine. Then you lose some of the safety data because you have no one to compare it to now, because now everyone's gotten the vaccine, but you also get a lot more data on the efficacy and how if it works and how long it works. So there's pluses and minuses on each side.
Awesome, thank you. What will be the criteria for declaring this pandemic under control and eventually no longer active? Dr. Anderson, do you want to take a stab at that one?
Yes, I just put something in the chat. What happens is something becomes an epidemic when we see more numbers of that condition, whether it's a chronic condition or an infectious condition than we would expect to see in a certain place during a certain time. So when initially SARS-CoV-2 became apparent in Wuhan, China, it was considered an epidemic because there were more infections of SARS-CoV-2 happening in Wuhan than would have been expected in that place at that time. It became a pandemic when across the globe, we saw more infections than we would expect in the place, at that time. So to get back out of pandemic status, we would need to see a significant decrease in the prevalence of this virus per population and place. And then that would need to be sustained. So we have a vaccine giving us a lot of reason for hope. We're going to have some time within which the vaccine will need to be combined with our the things you see on my screen here, our basic prevention methods. And then we can envision getting the numbers down so low that we are not going to be concerned that they will get us to a place where the burden from them will be so high that we won't be able to do our routine things. So it's coming, but it's going to require significant mitigation to get there. And then that mitigation combined with prevention will keep us low.
Dr. Cheryl, on that note, I'm sorry, I'm so used to calling you by your first name. My apologies.
Oh, Father Mark, it's fine.
I'm sorry. And it goes for your husband as well. I'm sorry, both of you. I mean, no disrespect.
No.
I wonder if you could speak to, either one of you could speak to, I know there are a lot of gamblers out there, but if we could just get a sense of a forecast. What's your sense of, I think you spoke to this a little bit the other day when Maureen Hoverness and I were consulting with you over some issues we were dealing with here at St. Bart's and some decisions we had to make. And part of that was trying to anticipate our preschool for next fall, which led to a conversation about assumptions that we're having to make and the planning we're doing, like every organization is doing right now. And so I guess the question underneath that is, do you anticipate in 2021 an easing? We'll get to a place in 2021, will be enough vaccinations out there that we'll be able to start to ease some of the protocols that many of us are trying to adhere to.
Yeah. If things go well, yes. However, we have now created a state of affairs in this country where people don't necessarily trust science. They don't have faith in authoritative medical groups. We have, even before this year, within certain populations in the country, a sense of mistrust in how they get treated, how they're welcomed or not welcomed to the table for medical therapy. And so we have a difficult road ahead of us, right? It's going to be a bit of pushing a boulder uphill in certain populations in the beginning of 2021. And you can contrast that with individuals who say, me first, forget, everybody else. I don't care about the prioritization scheme. I've got money, I've got power, I've got privilege. I'm headed straight to the front of the line, right? So we'll need to reconcile, both of those perspectives and try to get ourselves to a place where we respect the science, the various things that, Dr. Gwathney has laid out for us this morning, where we acknowledge and own some of the mistakes that we've made in certain communities, the Tuskegee syphilis experiment, for example, where we acknowledge and own that the lack of a national strategy around COVID-19 has left us in a place where roughly half of our country are saying, really, is this a big deal? We also have a more recent movement toward anti-vaccination. And we, if everything doesn't come together well, we could find ourselves with, some people having the vaccine, both doses of the vaccine, creating a reasonable percentage of the population with good immunity. However, if we can't quite get ourselves up to that 70 plus mark, because this is a highly contagious virus, we'll spend some time still in our masks, still, thinking about being distant from each other, still needing to, make sure that hygiene protocol is well fitted, because we'll need to get everybody on board. So I have hope, but at the same time, there are some serious considerations at play.
All right, a few more questions coming in. Can you speak to the disparity of infections in different populations based on race, ethnicity, and socioeconomic status? What are the root causes? Is it systematic racism, social economic disparity, cultural behaviors?
Yeah, maybe I'll start, and then I'm sure Dr. Gwathney will be able to round out some of this. So the first thing that became apparent to me as I was watching this pandemic unfold was the geospatial differences that we could see from the numbers that get tracked at the Johns Hopkins pandemic tracking location. And what we saw was first this pop up along the coast, right? Areas where you get a lot of international travel. And then we started to see the spread across the country, and a spread that is all too familiar to me because of the science that I do and that I've done for all of my career. And what I was starting to see was individuals for whom all of the chronic conditions that are problematic and that kill our men and women here in this country were the way that those get geospatially laid out was the pandemic was mimicking, how that same layout. And so you started to hear this conversation emerge around, wow, there are these inequities that are piling, and we saw COVID-19 really be a master class for us in how those who already bear a disproportionate burden of medical conditions now are bearing a disproportionate burden of COVID-19. Okay, what is at the root of all of that? Well, you could say, wow, when we splice our data by racial ethnic groups, we see that it's a racial ethnic situation. Certain racial ethnic groups in California, it was our Asian Pacific Islanders. The mortality in our Asian Pacific Islanders was just exceedingly disproportionate from that of other communities. We also saw that across the country for Blacks, African Americans, Latinx communities, the differences in infection as well as in mortality was quite disparate. Now we start to ask the question, is there something inherently going on with Black and Brown people, with Asian Pacific Islander communities that would cause them to be infected or cause them to be to die more readily? Or are there root issues that are at play in the communities that individuals who are brown and Black and other people of color live in? And so we can make the connection in public health to some clear systemic things. Access to healthcare, where people are located in a town, the number of essential workers. And by essential workers, I'm not talking about frontline doctors and nurses. I'm talking about individuals who deliver our goods and our services, individuals who drive those goods and services across our land, individuals who are, coming in to ensure that our cleaning protocols are at play and aren't able to work remotely or, be in some of these professions that could have transitioned into a space that doesn't put them at high risk for infection. So yes, there are structural and systemic issues that underlie how we get to a place where we see this difference happening in racial ethnic groups. We also know that the levels of food insecurity, being unsheltered, things that are just basic needs for us to thrive, are also playing out during this pandemic and impacting how people fare if they get infected by this virus. So a complex, complicated web of interactions, and there are definitely structural issues that on the other side of this, we are not going to be able to escape addressing if we don't want to find ourselves here again. And as an epidemiologist, I will tell you, I saw my husband leave and go fight Ebola. I was a kid when the HIV/AIDS epidemic started, but many of my colleagues were in hospitals when that pandemic rolled out. And it's just a matter of time before our next pandemic. And so let's learn something this time, and let's bring those things forward and create better infrastructures so we don't see this difference so intensely the next time we go through this.
I'll just really, really quickly, I couldn't agree more with everything that Dr. Anderson said, and potentially trying to be part of the solution with NIH studies. One of the many reasons why I decided to volunteer for the study was that not enough African Americans, Latinx, Asian Pacific Islanders are actually involved in these studies to be part of the solution. But both of these studies, normally in NIH studies, maybe 5% African American participation rates, when African Americans make up about 13.3% of the country. Both of these studies, both Moderna and Pfizer, had about 9.5, 9.6% African Americans, 20%, 25% Latinx participation. So they were represented well in these studies. And so we know that the vaccines work in any different age groups, any different chronic conditions, any different racial and ethnic disparities. So encouraging people to participate in these studies so we can be part of the solution and know it works for different populations.
All right, thank you. Another question for frontline healthcare workers who have underlying health conditions, whether it be age, certain diseases, that put them at risk of serious health impacts if they get COVID. Should they be requesting either leave of absence or reassignment to protect their health and the health of others?
So requesting a leave of absence, that's definitely a personal choice, personal decision. I think as healthcare providers, we signed up to help others, and sometimes there's a nominal risk associated with that. I think that's why healthcare providers were first in line to get the vaccine. So I would definitely encourage you, if you're older or have chronic conditions and are a healthcare worker, to definitely sign up and get vaccinated as soon as possible to help protect you. I didn't talk about, so once you get the vaccine, the Pfizer is 21 days later, you get your second dose, the Moderna is 28 days later. And we found that you get your immunity about 7 to 10 days after your second shot, whichever one you get. So I would say taking leave from a job is definitely a personal decision. I've had conversations with other doctors back east, and they were considering that because they have lupus or chronic conditions. They decided to continue working back then, but that's definitely a personal choice.
Sure, thank you. One question coming in: what is the latest on the news about there being a variant of COVID?
Look at that. Dr. Anderson was all over that, had me investigating all of that yesterday. So yes, in the UK, a new variant that was supposed to be 70% more transmissible. And so things that we don't know that will affect how this goes. They don't think that it causes any more severe disease. So maybe 70% more people get it, but it doesn't make you any more sicker than getting the other variant. And they don't think that the new variant, the mutation, will be affected by the vaccine, or the vaccine will still protect you against it. That's what they think right now. I don't know the specific mutation for this new variant, and that's what would actually tell us whether the new vaccine works against this new mutation. We usually talk about the spike protein. And if there was a mutation on the spike protein that made it different, then that would, affect the vaccine. But if it's a mutation somewhere else, then it wouldn't affect it. And just to note, they have catalogs of people's samples, and right now maybe 90,000, 100,000 samples. And there are right now 12,000 different mutations right now already of the actual virus that we have. Most of the mutations make the virus weaker, most of them. So every time we hear about a new mutation, there's already 12,000 of them out there already. So
I apologize for laughing, Doctor. 12,000 variants already?
Already, yes.
Is that normal with something like this?
It can be, yeah. And when we call, we can get into the science, but different codes and one amino acid out of, thousands. If you get one amino acid, that's a new variant. And so we're still pretty confident that the vaccine should work against this new variant right now, but that remains to be seen.
So just to, bring this home for everyone, you could think about flu, influenza, right? We deal with influenza every year. Coronavirus will be with us. We'll deal with coronaviruses for the rest of our existence. It really becomes a matter of, just like with the influenza, every now and then you see one that makes you go, uh-oh, wasn't ready for it, right? But our virologists and our vaccine scientists are working constantly at trying to anticipate what flu variants will come up in any given flu season and creating the vaccines that are appropriate to combat those. So when we saw H1N1, for example, we were like, because we weren't quite ready to address the H1N1 variant. Nonetheless, we got through it, and it'll be that way with coronaviruses in the future. We just have to get people to want to trust science, and this anti-vaccination movement will make all of our lives more difficult, and it will change the nature of how we interact with each other for quite some time.
In an odd way, for me at least, thank you for normalizing how science and the body and all this stuff works. Because I can imagine trying to read this on the front page of the paper every day and having a heart attack every time I read it. Thank you.
Thank you, Dr. Anderson. Another question that's come in, and 'tis the season for holiday gatherings. One of our participants would like to know, is the recommendation still parties under 10, or should there even be more caution with the current rise in cases?
Yeah, so I'll start and I'll invite Dr. Gwathney to come after. I would like to reiterate that we're currently under a shelter in place, a stay-at-home order from our California Department of Public Health. And what that means is that unless you are leaving your home for an essential activity, you shouldn't really be leaving your home. And that in and of itself suggests you shouldn't be leaving your home to go into someone else's home. You shouldn't be leaving your home to gather for activities that aren't necessary for your work or for your livelihood, etc. The reason why I think a lot of people may struggle with some of the grayness of this is, can I leave my home to go exercise? Of course, our health is about physical, mental, spiritual well-being, and all of those things get better when we go for exercise. Now, do we go for exercise in gatherings? No, not unless it is absolutely essential that happens. And I can think of very few instances where it would be. Similarly, the holiday party. Is your holiday party an essential activity? You've got to answer that for yourself. I can think of no instance where I would define it as an essential activity, but others might. And so that's the overarching state of affairs right now. Yesterday, we had over 3,700 infections on the books, not to mention the ones we didn't catch, right? We had that many on the books. Father Mark will remember me having a conversation with the leaders of the diocese when we were worried about 200 infections per day. When things had gone to 400 infections per day, we are at 3,700 infections per day. So we should all be asking ourselves, do we really need to have a holiday party this year? I cannot answer that for you, but I will tell you the numbers that I'm seeing and the names of people like my own aunt, who's died from COVID-19, my colleagues, largely brown and Black folks in this town, who either themselves are struggling or their family members are struggling. I would say, give it a second thought.
Thank you, Dr. Anderson. Dr. Gwathney, anything you care to add?
I could not have said it better myself. Please stay home.
So
Thank you.
yeah, thank you both doctors. I hope now those of you listening today can understand the advice we've been getting, as Dr. Anderson was mentioning over the months through the diocese, and let alone directly here to St. Bartholomew's, as the numbers, but the current numbers are just so off the charts. I used the word dire when I spoke to Dr. Anderson the other day. Is this dire? And she said, yes. And I said, is it going to get worse? And you said, yes. And I actually can't fathom that, doctors. I know the numbers are bad. Every time it gets bad, I can't imagine it getting worse, even though I've seen the charts, I've seen your charts, and I go, oh my gosh. So here at St. Bartholomew's, we are slowing down anything, except for a few things where there's no engagement on campus, except for a few things.
And think about it. I mean, body bags. We're ordering extra body bags. We've got portable morgues. I mean, is that gathering really that essential this year?
I have to say, I mean, that's why I think the vaccine is going to be so critical in moving this needle, because it's something that people only have to do twice. They don't have to continually do it. Unfortunately, we're not a great country at following the rules when we're told to do something. We're free. We have our own rights. Literally just last Friday, I'm in Del Mar, and I go to pick up food, and there's a party going on outside. 40, 50 people, music playing at a public space. And I said, this is not right. And, I did my part. I reported it. Maybe some other people reported it, and it was broken up. But unfortunately, people aren't willing to, do what they need to do to get us past this. So that's why I think the vaccine is going to be so helpful. They can go in, get a vaccine twice, and then hopefully that can help.
And Jamal, between now and when most people become, on the list prioritized for the vaccine, we can't have another, 50,000 deaths in this country.
Right.
We can't have bodies just sitting outside. We can't have 10 ambulances in front of the ER without people being able to get in. This space between today and when we are all gonna get up to get up enough in the line to get the vaccine, those are lives being lost unnecessarily. Right? So the vaccine is a beautiful thing. We have a space to cover between now and then that it's going to take all of us, and we're going to have to get through the fatigue and the frustration to really support each other and prevent these unnecessary deaths.
Thank you. Dr. Anderson and Dr. Gwathney, one of the things we're seeing discussed a lot is if I were to get the vaccine, does that give me permission to stop wearing my mask, stop social distancing? What would you say to individuals who may have that question?
The answer is no, unfortunately, for right now, because I'm always a positive person. So no for right now. We still need to continue to wear our masks, socially distance, wash our hands. And hopefully that will be for the short term until we get to that herd immunity level where enough people have been vaccinated. I've had discussions with different organizations. So if a group of people who all had been vaccinated wanted to get together, would that be okay? And from a physician and public health standpoint, I'd be okay with that. And I put in the criteria at least 2 weeks after your vaccination, because that's when your immunity actually kicks in. But if you had documentation, okay, I've been, vaccinated, and we'd still socially distance, and you'd probably still wear a mask. But you could, I would support things along those lines if you had documentation that you've been vaccinated. So we've been having those discussions, but you still have to wear your mask.
Sure. A few more questions coming in here. Where do we get the vaccine?
So, I can, so the normal places that, the normal outlets for vaccinations. So if you're a healthcare worker, probably at your hospitals, when, you get down to the 65 and older, your doctor's offices, Walmart, CVS, different places will get the vaccines, and they'll be readily available once it gets down to those levels for each person. So the normal areas where you get vaccines, that's where they'll be.
Dr. Gwathney, when do you anticipate, based on the current information you have, when the general public will have access at Walmart, CVS, their doctor's office?
Yeah, I'm anticipating probably late January, early February. Yeah, I think that would probably, yeah, because they're producing, Pfizer and Moderna are producing, millions of doses to get out there. So probably, yeah, that time frame at the earliest.
All right. A question coming in. How do we explain having students and children going back to school in large groups or businesses staying open, but encourage families to stay distant?
Yeah, so this is a really interesting question. The key here is that businesses, schools, any organizations that are currently considered essential and that are up and running have likely been doing this for quite some time, and they have protocols that allow them to minimize the risk of getting transmission in their spaces, or when there is infection present, they are able to do the kind of public health interventions that are necessary to prevent the inadvertent spread. So that is a different setup than, me inviting individuals over to my home. Let's say I decided to have a party of 10 friends. They're all coming from 10 different backgrounds with, 10 different levels of potential exposure and risk of transmission patterns. I'll give you an example. Back in the HIV/AIDS epidemic days, we learned a lot about when you had a partner, a sexual partner, you were not only engaged with that individual, you were engaged with everyone that individual, had been engaged with as well. And similarly here, you invite over a group of 10, you're not just with those 10 people, you're with all of the people that those 10 people have been with. And if you are not committed to keeping excellent logs, to having a pattern of testing and infection tracking, in our setting, we monitor mRNA in our feces. We monitor it, routinely in the blood of individuals. We monitor it in nasal samples. We are doing molecular epidemiology, looking at strains to understand, did something different come into the picture than was there before. So these are kind of coordinated, massive, robust efforts that are happening within businesses and schools, et cetera, to help keep those entities from minimizing risk. So I would say to me, that's a different standard than what individuals experience when they put a holiday gathering together.
So we live into that St. Bart's. Our preschool is open, but following the protocols that Maureen Hovenissen through Dr. Anderson and others helped us set up, we know that if we have a potential exposure in a classroom or a particular teacher, we know that actually we've got that tight in that group, we'll call that a pod. We know that the maximum exposure is just to that pod. We know that to notify the families immediately. We know whom to quarantine immediately, and we know whom may have to go get tested immediately. And then we know how to clean that space again, because only that pods you that space. We've closed the entire education building just so that one classroom can be open to those 10 children with those 2 teachers throughout the entire week. And that way, no one else goes in that room except for the cleaning crew, which comes through every day. And so we know how to clean that space afterwards, and then after the appropriate amount of time afterwards to allow those children and teachers who are not been infected back into that room. So that's just and at St. Bart, that's a very micro example of what Dr. Anderson was referring to as organizations having systems set up through protocols, through public health officials, standards, and licensing for schools, which is very rigid, and then implementing that continuously month after month, day after day. And so we've actually had to implement those protocols. Luckily, we've had no exposures in our school, but we've had to implement those protocols and they work. And we're very grateful.
Thank you. A question here, Dr. Anderson, is golfing outdoors with other households with no touching and only 4 people in separate carts or walking safe at this time?
Yeah, I'm going to add to that. Not only is there no touching happening, there's also masking happening and there's physical distancing happening. And yes, if you have your mask on, if you're at least 6 feet apart, and if you are not touching each other, you are likely going to be okay in having an outdoor activity that promotes your physical, mental, and spiritual health.
And I will add to that, and remember, when you get to the clubhouse, you still need to separate in the clubhouse, and you can't sit down and have a meal all together. So it has to be continuous. Yes.
That's right, Dr. G. That's right.
All right. Final question here. And folks, if you have any other questions for Dr. Anderson or Dr. Gwathney, please feel free to enter them into the Q&A portion of your Zoom screen. One here, I know that contact tracing has been very difficult for our public health department since the start of the pandemic. My thought is that it will be just important in the next several months for us to improve our contact tracing systems. What are your thoughts on that?
Yeah, thank you for that question. Yes, the importance of contact tracing is that it allows us to get individuals who have positive test results for COVID-19 aware of that positive test result into isolation, meaning away from others and out of circulation, with the explicit goal of not inadvertently transmitting the virus to others. Right? I don't think anybody wants to be out there, shedding virus, infecting other people. So we have this system in place that gets that person aware. Then that person tells us who they have been in touch with recently within the period that we think infections may have happened, and we get them aware so that they can, be mindful of their activities and not, again, inadvertently transmit this to others. We now have some digital solutions that can help us to not only talk with people and get them aware of the situation, but have our cell phones talk with each other. And those cell phones, when they're talking with each other, can let us know who we might have been in contact with over the periods of time where we might be infectious. So there is a system called California COVID Notify. And in fact, I am going to put it on my screen right now. And if you hold your cell phone up to the barcode on my screen, you will be able to download the app. So California COVID Notify will allow you, if your cell phone is within 6 feet of the cell phone of someone who has tested positive, to get notification so that you can go through the procedures like getting yourself tested, monitoring yourself for symptoms, being in quarantine for 5 or 7 days, depending on whether symptoms do not develop and a positive test result isn't seen, or for 10 days if you have symptoms and need to sort of wait that out. So these are very important strategies. And right now, I will tell you that county is stressed to the max. 4 out of 10 people who have COVID-19 are able to get a phone call, even just made to them within the first 24 hours. That is not okay, because that inadvertent shedding of virus will continue to happen if people are not aware that they have this infection.
Thank you, Dr. Anderson.
I'd like to add on for this California COVID Notify. A lot of people, the first thing they think about are privacy issues with this, and this is, actually very private. It uses the Bluetooth technology, so you have to actually put information into it, and then if you test positive, you have to actively put that information in as well, and it's all de-identified. And so if I were to come into contact with someone, they would just tell me you were within 6 feet of a person that tested positive on this date around this time, and you can figure out where you were, things along those lines. But it is very private and very secure, and I think it's great.
And in that same vein, how many people would you say would need to use this system for it to be effective in the county's contact tracing efforts?
Yeah, a lot of people need to get this downloaded. And what's happened is that UC San Diego started as a pilot site, and then we became the coordinating site for it about 4 weeks ago. And within the first day of us rolling this out statewide, 1 million people downloaded the app. So it had its initial rollout phase, and in its more recent evolution has had quite a bit of people in the system. So, it's just like everything, we need to do this together. And the more of us that band in for some of these solutions to work, the better.
Yeah.
Thank you.
How are we doing, Demetrius?
Well, we're doing well. One question that did come up, just to get that addressed, this recording will be available on YouTube for those who were unable to join us this morning. Dr. Anderson, another question popped up. If someone has an idea about how to improve contact tracing in our community, who should they talk to?
Yeah. Well, there will be, if all goes well, an opinion editorial piece that I have co-authored with a colleague of mine who's a distinguished professor of public health at San Diego State University. And we're calling for a workshop to happen within San Diego County before Christmas. So in the next 3 or 4 days. And the whole idea is to get individuals like yourself, our political, our policymakers, our politicians, our scientists, our hospital CEOs, the various stakeholders of this community to the table with the explicit deliverables of figuring out how do we improve services, public health and healthcare services in this very critical time. So stay tuned for that. It's right now sitting on the editor's desk at the Union Tribune. But we'll get that publicized because, again, public health is for all of us and it takes all of us. So we'll get you to the table in that format.
Thank you. One other piece that has seemed to pop up a lot is, if I have already had COVID, should I get the vaccine? You both did address it, but just for anyone that joined us late, if you could just reiterate your suggestions for that.
Sure. So again, if you've had coronavirus, you can get the vaccine after having coronavirus. You may delay for 90 days if you so choose, but you don't have to. We only say if you're currently sick with coronavirus, you should not get the vaccine. If you haven't been cleared and done your 10 days of isolation. But after that time frame, you certainly can, and you have the option to delay because your risk of getting infected within that first 90 days is relatively low.
Thank you. And a question comes in about, is there a strategy for getting local media, specifically TV stations, on board with getting out information about COVID-19 and safety practices?
Yeah, so yes, there's a strategy. I think the question is, how well are things working right now? Which is, as a dean of a school of public health, is my call for action is to get all of us in the room. This would include media as well. They're so important in how we message things out, so that at this critical time, we can provide the kind of persuasive, effective messaging that will address a frustrated and fatigued public.
And I think the media is very important, but the format in that communicating. So not only the message, but how you're getting it out. How I communicate with a 20-year-old is very different than how I communicate with a 70-year-old. And so factoring those things in are very important, not only the message, but how we're getting it out to people.
That's right.
If I may, Demetrius, before we wrap this up, we are a church, and I know where you all worship. And so if the two of you wouldn't mind, just a short, where's your hope? And where we're at and where we're going. And just, if you don't mind drawing that into your faith life, we would all welcome to learn from your own testimony.
Yeah. Well, I'll start by saying I am in vocation. When I do this work, it is my heart's joy to do it. And in both a faith context and a public health context, we're often thinking about how do we get things done? And we can get things done by doing things to people, right? But many of us would say, yeah, that's probably not optimal. We don't just want to go doing things to people. We can do things for people, right? And that's common. We go in, we start programs, we do interventions, etc. We can do things with people, which I think is probably how within our church, we think about how do we form partnerships so that we can successfully transform lives. Within public health, we're doing the same thing. We're forming partnerships to successfully transform lives. And then we aim for this higher space of how do we build capacity so that individuals and communities can do things for themselves. And so in this walk, in trying to get us through the pandemic, I've seen all of those various states happen. And I am hopeful for us using this, again, COVID-19 has been a masterclass. I mean, using this to get us to a place where we, in true partnership, build capacity with communities to ensure that we get to the other side of this, and that when that next one comes our way, we're not struggling like we are right now. So there is my hope and the joy in this work.
And I'm not as eloquent as Dr. Anderson by any stretch, but I too am hopeful. I'm an optimist at heart. One of my favorite quotation by Dr. Martin Luther King Jr. is, life's most persistent and urgent question is, what are you doing for others? And so I think that's what a lot of people in public health kind of live by. And I think I'm hopeful that not only us, but we as a community, as a church community, as a nation, as the world can come together to help others, to help each other. I think the science has pushed us forward by leaps and bounds. And if we continue to trust in that science, that will certainly bring us forward much faster. But I am hopeful in that the faith that we have, and the church, that things are going to get better sooner rather than later.
Thank you. I think we all needed a shot of hope. So thank you from both of you. Demetrius, anything else before we wrap?
That's it. Dr. Anderson, Dr. Gwathney, if there are any closing thoughts that you would like to share with people, please feel free.
Okay, really quickly, I always just end with, vaccines don't save lives, vaccinations save lives. So you have to get the vaccination for it to work. I'll end there.
Yeah, thanks everyone for allowing us to be in this space with you today. Both Dr. Gwathney and I recognize that having this kind of trust placed in us is not a small thing. And we are grateful to be a part of this broader community in the diocese and to always feel so welcomed in the St. Bart's community. So thank you.
Absolutely. And Dr. Anderson, Dr. Gwathney, thank you so much for your expertise and your insight into perhaps one of the greatest public health challenges, at least of my lifetime. But thank you very much for joining us today. And we hope to be in continued dialogue with you both soon.
Thank you.
Take care.
Yeah.